Good morning, everyone. It's a pleasure to present this topic today. I chose this title because of the symbolic similarity between river Styx and dural arteriovenous fistula. If you have malignant symptoms and you don't treat that, then you would eventually have catastrophic complications, and thus you'd be in the world of the dead. So we don't want that to happen. Now, without further ado, So, river Styx, as most of you know, it's in Greek mythology is a river that connects the world of the living to the world of the dead. And there's a ferryman with a boat that transports the dead on his boat. In Greek tradition, all dead people would have a coin or an obol in as a Greek currency to be inserted underneath the tongue of the dead so that they would granted passage through the boat until they reach to the world of the dead. So the objectives for this presentations, first of all, we're going to define what is a dural arteriovenous fistula, then the etiology and pathogenesis of dural AVFs, the hemodynamics of normal vessels, and we can apply that to dural arteriovenous fistulas. Then we have multiple classification scheme of dural arteriovenous fistulas. Then we're going to jump to the natural history, the presenting sign and symptoms. Then we're going to conclude with imaging and management. So, as most of you know, dural arteriovenous fistulas are, it comprises of an abnormal connection between an artery and a draining vein. You can differentiate that from an AVM because it does not have an itis, which is present in AVMs normally. And it's generally a low flow vascular lesion. So the pathogenesis of dural AVFs, it's mostly acquired versus AVMs where you are born with, it's congenital. And the thought about this is you have venous hypertension induced by multiple factors such as trauma, thrombosis of a vein, surgery, infection, and this would all culminate into a venous hypertension type of picture, which would lead to new vessel formation or angiogenesis by hypoxia-induced factor 1 or vascular-induced growth factor. Now, briefly, as you all know, the famous Ohm's law, and I'm pretty sure if Dr. Marcos is here, he's going to chew me up on the pronunciation of this name, Poiseuille's law. So these are two famous equations that are really difficult or not, you can't really apply them completely to blood vessels because blood vessels are dynamics. They're not metal pipes. Generally blood vessel is not completely laminar. The blood flow inside, it has some turbulent flow inside. So, which is why in dural AV fistulas where you have venous hypertension, this would exacerbate the turbulent flow, and thus you have the formation of new arterial feeders to venous drainage, channels to the sinus. So you have recruitment of these small dural or pial arterial feeders or tributaries to the venous sinus, and this would ultimately lead to venous dilatation and retrograde flow formation, which we'll talk about in a bit. This is a good diagram that I found in one of the older publications where it talks about the etiology of dural arteriovenous fistulas that will lead to venous hypertension, dural AV fistula formation, which can either thrombose and cure itself, or it can cause generalized increase in venous pressure, such as if you have a superior sagittal sinus complete thrombosis, or you have an ICP, or you have local venous pressure increase that would lead to non-hemorrhagic neurological deficits, or hemorrhage. Now, going to the classification scheme of dural AVFs. So the first one is Borden-Schuchart, the famous classification, which is mainly, it basically talks about the venous drainage pattern. So if you go to diagram A, this is Borden type A, where you have an arterial feeder connecting to a dural sinus, and this has an anterograde flow. Now, in comparison, you have type B, which is in diagram B and C, by the way. You have an anterograde flow that by time you have an arterialized sinus that would either partially occlude or thrombose that will lead to retrograde cortical venous drainage with an anterograde venous flow. In type C, you have complete occlusion of the sinus. So you have an exclusive cortical venous drainage. The other classification is Conyard classification, where it basically talks about the angioarchitecture in addition to the venous drainage pattern. In type 1, you have an anterograde flow. Basically, you have a dural artery that connects to a venous sinus, and you have an anterograde flow, versus type 2A, in this picture where you have retrograde flow in the sinus. Type 2B, you have anterograde flow to the sinus with cortical venous drainage. And type 2A and B is a combination of both. Type 3, Conyard classification, is where you have exclusive cortical venous drainage. And in type 4, these cortical veins would dilate, or you have venous varices. Type 5 is where you have a cortical vein that drains into a perimedullary venous system. So the presentation natural history of dural AVFs, they're not as common as other vascular malformations. They comprise 7 to 15% of all intracranial vascular malformations. They're common in those who are in their 50s and 60s. And there's really not much distinction between which is common if it's in males or females. They're usually like equal between both. But males are more likely to have hemorrhagic complications, and the incidence is 0.16 to 0.51 per 100,000 adults per year. Now, location-wise, you have multiple locations that would harbor the dural arteriovenous fistula. The most common is transverse sigmoid location, which comprises 31% of dural AV fistulas. And then you have tentorial location, which is the second most common, that comprises 17%, followed by petrosal, dural arteriovenous fistula, then ethmoidal, which is 8%, then the superior sagittal sinus, which is 7%, then cavernous fistula, which is 5%. And then you have other locations such as the craniocervical junction or torcular drainage pattern, which is the remainder, 24%. So the signs and symptoms can be classified into three classifications. So you have a benign presentation, which can be pulsatile tinnitus, bruise. Headache can be benign or really can be malignant based on the severity of the headache. Then you have non-hemorrhagic neurological deficits, which include motor weakness, seizure, dementia, ataxia, and then you can have bleeding as a result. So low-grade dural arteriovenous fistula, such as Borden 1 or Conyard 1 or 2A, have 1.4% annual rate of conversion to high grade, such as Borden 2-3 or Conyard 2B up to 4. Borden 2 and 3 have an annual ICH rate of 6 to 10%, respectively. The asymptomatic Borden 2 and 3, however, have an annual ICH rate of 1.4% versus 7.6% in symptomatic patients. The annual ICH rate for patients with non-hemorrhagic neurological deficits is 10%. And those with previous ICH, you have 46% developing another ICH. So the rebleed rate within the first month is actually pretty high, it can be 35%. This is another classification developed by Zipfel et al., where they focused on the um, formation of ICH. And as we talked about, Borden and Conyard are both related to the venous flow and the angioarchitecture. Zipfel et al. Combined both classification schema and based on the cortical venous drainage and the signs and symptoms, then you'd have, the chance of developing ICH instead. And based on that chance, then you'd have either elective or immediate urgent treatment to prevent non-hemorrhagic neurological deficits or ICH. So Condor is it's a consortium that combines multiple centers, patients with dural arteriovenous fistula, and so far there are more than 1,000 patients in that consortium. So they have been publishing recent papers, and one of these papers actually talks about dural arteriovenous fistulas without CVD or cortical venous drainage. Even though it's benign, quote unquote, it still has a 12% risk of non-hemorrhagic neurological deficits, and the ICH risk is 1.5%. So it's not as benign as what we thought as before. And really, poor outcome of dural arteriovenous fistula without cortical venous drainage if you have a patient who are old, or if it's an infratentorial location, you have non-hemorrhagic neurological deficits, or you have severe venous hypertension symptoms such as severe headache or orbital symptoms. So imaging modality, we know that DSA is the gold standard, even though we use CTA or MRA, which are helpful in finding the arterial feeder and the venous drainage. It still lacks the direction of flow and the space-time imaging of these fistulas, which are very vital for treatment. So in this image, you basically want to find the arterial feeder, which is here in the thin arrow, from the occipital artery and from the STA. And then you want to locate the venous drainage, which is in the thick arrow here, that goes to the transverse sinus, transverse sigmoid sinus. Then you want to see the direction of flow, and finally you want to make sure there are no cortical venous drainage. In this image, you can see the asterisk that points at the cortical venous drainage. This is another classification from a recent paper by Kim et al. Last year in 2022. That it basically, they talk about the angioarchitecture of dural arteriovenous fistulas, and based on that, they classified it into 4 different classification. The first one, or type A, is just direct connection to a dural venous sinus. And then you have type B, where you have, it's basically called compartmental dural arteriovenous fistula, where you have either partial thrombosis within the sinus, or you have septations within the sinus that dural arterial feeders drain into. And then you have type C, where you have a mural vessel that drains all of the arterial feeders and ultimately drains them into the venous sinus. And then you have type D, which is direct drainage into cortical venous vein or drainage. So from that paper, the direct cortical venous reflux can be seen mostly in the bridging vein shunt, which is type D. And the indirect cortical venous reflux can be seen in the compartmental sinus channel, which is type B here. So for the management of dural arteriovenous fistulas, we all know that nowadays endovascular treatment is the primary modality for treatment. And the goals for endovascular treatment is complete obliteration or partial obliteration to stage it into surgery or radiosurgical treatment, or sometimes for palliative symptom management. Someone who has tinnitus, pulsatile tinnitus, and that's it. Thank you so much.
All right. Hey, good morning, everyone. I just want to thank the faculty and everyone else for the opportunity to speak today. My talk's just going to go over a historical review of how extent of resection thresholds were established for glioblastoma surgery. Also go over some changing paradigms in regards to what we define as maximal safe resection, and also discuss some new technologic advances that may be able to aid us in expanding the frontiers of resection. Also, just want to give a special shout out to my co-resident Ahmad Jamad. It's his birthday today, so anyone who sees him, wish him a happy birthday. Yep. No conflicts of interest to disclose. So for our objectives, so today we'll be working on identifying how resection thresholds were established for survival benefit in GBM to assess whether supramaximal resection beyond the contrast enhancing border may serve as an adjunct to grossal resection in GBM surgery. And we'll also be identifying emerging technologies that may allow for greater, safer resections. So just a quick introduction. So, the first microscopic examinations of malignant gliomas were performed by actually Rudolf Virchow, the same guy who kind of, came up with Virchow triads and the Virchow-Robin spaces. He believed gliomas were tumors that originated from cells that held together the parenchymal matrix. So he named them after the Greek word for glue. His work was later expanded by another pathologist, Heinrich Strobe, who advanced his work and later confirmed the infiltrative nature of gliomas and stratified them further into histologic subtypes. His work kind of introduced two major concepts. The first, that there was inherent intratumoral heterogeneity in glioblastomas, and that heterogeneity made it essential to do a multifocal microscopic examination of the surrounding tissue rather than a single or a confined portion of a single region. These two concepts kind of understated the aggressive and infiltrative nature of gliomas, which would further set the stage for their operative management. So initial efforts at the surgical treatment of brain tumors were kind of marred by very high operative morbidity and mortality. There were a variety of key players that are shown here that kind of expanded the surgical treatment of brain tumors, including malignant gliomas. The first was Sir Victor Horsley. He was one of the early surgeons that pioneered the variety of practical neurosurgical techniques that we use today, including the use of hemostatic bone wax. He was a strong proponent of early identification and surgical management of brain tumors. Philip Kuhn Knapp, who's shown in B, provided one of the earliest analysis of surgical outcomes for complete removals of brain tumors, including gliomas. Unfortunately, his analysis of surgical outcomes showed that it was extremely difficult and dangerous. And in his report, he actually was quoted saying, the chances of success are few and the outlook of the future is more hopeless. The next person who kind of pioneered brain tumor surgery and significantly reduced operative morbidity and mortality was actually Harvey Cushing, who's shown in C. Cushing's dedication to technical perfection and his understanding of ICP dynamics led to a considerable reduction in mortality during his practice. He pioneered two main things in terms of glioma and brain tumor surgery. The first was a concomitant subtemporal decompression as a means of reducing mass effect for brain tumors in the temporal lobe that were otherwise considered inoperable. And then the second was he worked very closely with his neuropathologist, pathologist, Dr. Eisenhardt, to pioneer intraoperative pathology consultation. And then lastly, the person I kind of want to mention was Dr. Dandy, who was, of course, a student of Dr. Cushing's, who introduced ventriculography, which helped aid localization for the surgical treatment of brain tumors. And he was kind of a little bit at odds with his teacher, Dr. Cushing, in that he was extremely aggressive in glioma surgery. Dr. Cushing, in determining, some tumors as inoperable, would often advocate just for a palliative subtemporal decompression, whereas Dr. Dandy was often extremely aggressive and he was quoted as saying a large percentage of brain tumors are infiltrating, and the removal actually requires the additional removal of a zone of healthy brain tissue. In 1923, actually, he was the first person to do a complete hemispherectomy for glioblastoma. So the concept of lobectomies for gliomas were first introduced in the early 20th century as a salvage treatment for an otherwise dismal prognosis. It was said that solid gliomas presented a fairly hopeless situation unless they were so situated that a lobectomy could be performed. In 1928, Walter Dandy described 5 cases of hemispherectomies to remove right hemispheric gliomas. It was said that after removal of the entire right hemisphere, patients showed otherwise no apparent mental impairment except for the anticipated hemiplegia. Additionally, in later series, operative morbidity for lobectomies remained incredibly high with a mortality rate of almost 50%. After these outcomes were reported, the benefit of further removal of normal-looking brain tissue was called into question, and since then, most neurosurgeons have focused on removing what was apparently visible on MRI and intraoperatively, hence termed the gross total resection. With the advent and introduction of the operative microscope, glioma surgery became much more safe, and extensive resection were able to be expanded. The initial series with the microscope showed that there was no significant difference in survival between performing a lobectomy versus a traditional lesionectomy, with an overall survival of approximately 12 months in both groups. Shown below are the initial Kaplan-Meier curves, comparing surgery with and without the use of the microscope by Haller-Hage and colleagues. There was obviously a significant increase in median overall survival for patients undergoing microsurgery. With the advent of intraoperative direct cortical stimulation and functional mapping, glioma surgery was even further improved in terms of being able to further increase the margins of resection, as well as decreasing the risk of postoperative neurologic morbidity. In a systematic review and meta-analysis led by Dr. Mitch Berger over at UCSF, it showed that awake craniotomy with intraoperative brain mapping allowed for improved rates of gross total resection with minimal postoperative neurologic deficits. And then consequently, over the last decade, we've established a variety of thresholds for extended resection for GBM that end up conferring a survival benefit. And it seems that over time, the suspected maximal threshold for resection needed to confer a survival benefit has interestingly decreased over time, likely secondary to the introduction of associated adjuvant treatments such as temozolomide and radiotherapy. So the first series done by Dr. LaCroix in 2001 showed that they needed a 98% resection of contrast enhancing burden to confer a significant survival benefit. But later studies by Dr. Sinai in 2011 showed that that threshold actually went down to 78%. And more recent studies by Dr. Chachana up in Mayo Clinic showed that that threshold was even lower, and they showed that approximately 70% resection was able to confer survival benefit. All of these studies validate that tumor resection should be maximized, of course, without increasing neurologic morbidity, essentially a maximal safe resection. However, there remains a question of whether resection of the contrast enhancing rim or contrast enhancing border of the tumor is enough. Dr. Pat Kelly's work in the 1960s suggests otherwise. So his work demonstrated that tumor infiltration or microscopic tumor infiltration extended well beyond the contrast enhancing portion on CAT scans. This is shown here. And this again reminds me of Dr. Dandy's quote, a large percentage of brain tumors are infiltrating and their removal requires the additional extirpation of a zone of healthy brain tissue. So now we can fast forward 50 years to the concept of modern day supramaximal resection. The first reports of modern supramaximal resection were described in France by Dr. Hughes Defal for low-grade glioma using awake surgery to maximize the extent of resection. This concept was then translated to high-grade gliomas by Dr. Defal and another group from MD Anderson Cancer Center that demonstrated that resection of 50% of peripheral flare enhancement added a additional survival benefit. So we sought as well to understand if lobectomy for non-eloquent newly diagnosed GBM would offer a similar survival benefit. We performed a retrospective propensity match study to eliminate selection bias. Inclusion criteria were as follows. Include all patients who met criteria for supramaximal resection and gross total resection. Any patients who underwent previous resection or treatment were excluded. We collected obviously all relevant clinical pathologic data and included those in our generation of propensity scores. All patients, of course, completed Stoop protocol postoperatively. Overall, this study was one of the largest lobectomy series with a total of 69 patients. 32 patients underwent lobectomies, 37 patients underwent lesionectomies. Of note, there was significantly more. This was prior to the new WHO criteria or definition of GBMs. At this time, there was for our cohort, there was significantly more IDH wild type and a higher preoperative flare volumes for our lobectomy groups. But of course, these were accounted for in our propensity score analysis. So this is just representational images for a few selective examples from our lobectomy and gross total resection cohort. Our primary outcomes were overall survival and progression-free survival as defined by the RANO criteria at that time. So after using something called inverse propensity of treatment weighting, which basically weights a patient's survival outcomes using their propensity scores that were generated, we found that the overall survival and progression-free survival were significantly greater in our lobectomy cohort compared to the patients receiving lesionectomies. The median overall survival was 30.7 months in our lobectomy cohort compared to 14.1 months in our lesionectomy cohort. And a similar improvement in progression-free survival was observed as well. So this was our first study that kind of suggested that lobectomy for non-eloquent GBMs conferred in, added survival benefit compared to just gross total resection alone. However, the question remained whether or not supramaximal resection was a viable treatment option for those undergoing surgery for gliomas in or around eloquent regions of the brain. So our next study sought to answer that question, where we evaluated the survival benefit, safety, and efficacy of radical supramaximal resection for left-sided eloquent newly diagnosed glioblastoma. We screened 641 total patients. Inclusion criteria was shown on the left. Those patients were then narrowed into 102 patients with primary newly diagnosed GBM that met the inclusion criteria. 54 of those patients underwent gross total resection. 48 of those patients underwent supramaximal resection. We did propensity matching based on age, functional status as measured by KPS, and tumor location. And then our matched cohort ended up with 27 gross total resections and 27 supramaximal resections that underwent a survival analysis. And we ended up finding that compared to gross total resection, supramaximal resection conferred a significantly improved median overall survival compared to gross total resection alone in this cohort, 21.55 months versus 15.4. Interestingly, we found that there was a dose-dependent response between the amount of peritumoral flare that was dissected and the survival benefit conferred to patients undergoing supramaximal resection. As you can see, the image on the left shows overall survival. The image on the right shows progression-free survival Kaplan-Meier curves. The blue line indicates patients who underwent over 80% resection of their peritumoral flare volume. Green is 60 to 80, orange is 40 to 60, and then red is less than 40. And there's a pretty discrete dose-dependent response between the degree of survival conferred or survival benefit conferred and the amount of flare resection performed. So I hope I've underscored the relationship between the degree of cytoreduction performed and patient survival outcome in the surgical management of GBM. In addition, I hope to have made an argument, in concordance with the sentiments of Dr. Dandy, Dr. Kelly, and Dr. Defoe, that given the infiltrative nature of gliomas, aggressive resection beyond contrast-enhancing margins may be beneficial. Of course, this must be weighed against the preservation of neurologic function and minimizing neurologic mobility. So it's a very careful balance. However, luckily, given recent technological advances, there exists ever-emerging tools in our toolbox that may aid in doing so. So the next portion of my presentation will kind of go over some of the recent advances that have allowed us to kind of tip the scales in our favor. So the first thing I want to mention is the use of 5-aminolevulinic acid, or 5-ALA. 5-ALA has become a useful tool in terms of improving tumor visualization and improving cytoreduction. So in a recent systematic review performed by our group, we found that fluorescence-guided surgery using 5-ALA was significantly associated with improved extent of resection and higher rates of gross total resection. But we also found that there was an observed increase in the overall survival and progression-free survival for patients undergoing surgery with 5-ALA compared to white light alone. The problem, however, with 5-ALA is that it has an excellent positive predictive value. However, the negative predictive value, or the ability of 5-ALA to determine if there are negative margins, is quite abysmal. In a study by Dr. Roberts, the negative predictive value for 5-ALA was only 0.26. There's a variety of reasons that are suspected for this. It's suspected that diffusely infiltrative growth patterns within the brain. Because of this, a lot of GBM cells can be found directly, quite far away from the contrast enhancing tumor, which again was shown in, Dr. Kelly's histologic work examining this. Therefore, there may be low 5-ALA fluorescence in particular regions with low density of tumor cell infiltration. Therefore, there's a necessity for a different technology in terms of helping identify areas where there are negative margins or perhaps with a higher resolution. So the next technology I want to talk about was something called stimulated Raman histology, or SRH. And just making a quick jump back, intraoperative neuropathology has been an essential tool in the toolbox of neurosurgeons ever since the 1930s, when it was first introduced by Eisenhart and Cushing. During this time, they utilized simple intraoperative squash preps. And Cushing actually was quoted in this article as saying, possibly the most important immediate differentiation that is needed is between the various types of gliomas. It gives an immediate indication of the prognosis and determines what particular operative procedure to pursue and how radical or otherwise an extubation of the lesion is desirable. So this is our current workflow with frozen section, which is the current gold standard for intraoperative neuropathologic consult for neurosurgery. This remains a labor and time-intensive process, as you can see here. Time and manpower is needed to bring the pathology or bring the biopsy specimen to the pathology lab. Time is needed to process the tissue, slice and stain the tissue with traditional hematoxylin and eosin staining. Overall, this is a quite labor-intensive process, as I'm sure many of us have experienced here in the ORs. Stimulated Raman histology is an interesting technology that uses fresh, unlabeled, and unprocessed tissue and a one-step squash prep to assess the intrinsic vibrational spectroscopy properties of biological molecules such as lipids, proteins, etc. It provides the additive advantage of just using a simple squash prep. And in addition, any images that are produced can be immediately digitized to be sent for review to the board-certified neuropathologist in any center that has readily available Wi-Fi. In addition to that, because of the digitization of the data, this technology can be easily leveraged with neural networks and AI that can even further rapidly generate a diagnosis. We wanted to test this technology out in terms of identifying an adequate and efficient workflow. So we performed a 82-patient prospective study that compared the diagnostic accuracy between frozen section histopathology and SRH-based neuropathology in terms of identifying lesional versus non-lesional tissue, e.g. if a portion of tissue had normal brain versus tumor-infiltrated brain. In addition to that, we also compared agreement for the final diagnosis rendered using frozen section and Raman histology compared to the gold standard of permanent section histopathology. What we found was that intraoperative diagnosis using SRH significantly reduced intraoperative diagnostic time. So mean time to diagnosis using frozen section was approximately 40 minutes. And then mean time to diagnosis was approximately 10 minutes. This was with a mixed heterogeneous cohort, a variety of tumors, including gliomas, meningiomas, pituitaries, and METs. In addition, we found that SRH conferred a similar accuracy or agreement in terms of the agreement with the permanent section diagnosis compared to frozen section and permanent section diagnosis. the accuracy for SRH was 91.5% in terms of generating a accurate diagnosis, which was exactly the same as frozen section in this cohort. This is just a graph showing the number of cases and the time to diagnosis it took for each case. Dark blue is the amount of correct diagnosis made by SRH. Dark red is the amount of incorrect cases made by SRH. And the light colors are for frozen section, respectively. And you can show that there was significantly shorter time to diagnosis using SRH. These are just representative images showing the remarkable similarity in terms of SRH generated histopathology images. The bottom row shows a kind of pituitary adenoma. The middle images show the whorls seen in a meningioma, the meningothelial whorls seen in a meningioma. And then the top row is actually GBM. And the right image on the right is the SRH generated image, which actually shows that the tumor cells infiltrating the white lines, which are axons. So it shows the tumor cells infiltrating white matter. So this was a heterogeneous cohort of tumors. So we wanted also to see whether or not the results were applicable specifically to gliomas. And we performed basically a similar study in a cohort of just 21 gliomas specifically. And again, we found that the results were indeed applicable specifically to gliomas, who often are maybe a little bit more difficult to diagnose as they don't have as many pathognomonic features as, say, a meningioma would. Mean time to diagnosis for gliomas using SRH was significantly shorter, with a time savings of over 33 minutes. And again, the degree of agreement with permanent section was also similar between groups, showing that SRH diagnostic accuracy for gliomas is just as high as frozen section histopathology. SRH was also able to show clear histologic features classically associated with GBM, including multiple mitotic figures, which is shown on the left here, as well as a variety of other histopathologic features, including microvascular proliferation, parenchymal infiltration and infiltration into white matter, and pseudopalestinic necrosis. And then in addition to that, we found that the SRH was also able to help identify features of WHO grade 2 and WHO grade 3 astrocytomas compared to GBM. So shown here, lower grade shows mild cellularity, mild nuclear atypia, and perineural cytolytosis. And the higher grade shows higher cellularity, marked nuclear atypia, and a higher number of mitotic figures. As I mentioned before, one of the key advantages of using SRH is that it allows you a rapid assessment of tumor margins. And a recent publication out of UCSF between Mitch Berger and Dr. Hervey Jumper's groups showed the use of SRH in detecting glioma infiltration at tumor margins. And what they found was that specifically at tumor margins, SRH and frozen section showed similar agreement in identifying tissue infiltrated with tumor versus normal brain. So just given the rapid, rapid time savings afforded by SRH, this may be a kind of new frontier in terms of where this technology could be used at. As I mentioned before as well, one of the main advantages of using SRH is it being able to be leveraged with artificial intelligence and neural networks for rapid, accurate diagnosis. This was a study published by, I believe, Dr. Ivan, Dr. Kamatar, and Dr. Oranger in collaboration with a group over at University of Michigan that showed that a AI generated or a diagnosis generated using neural networks and SRH showed similar accuracy compared to formal diagnosis generated by two independent board certified neuropathologists. And then I just want to mention briefly a few last topics in regards to improving cytoreduction and improving neurologic morbidity for otherwise inoperable or deep-seated gliomas. One of these is laser interstitial thermal therapy, which is a relatively recent technology that has allowed us to significantly cytoreduce lesions in otherwise inaccessible areas. Laser interstitial therapy arose as a promising adjuvant to traditional surgical cytoreduction, and we've shown this in a variety of cases. It offers two primary advantages. The first being a method of minimally invasive targeted ablation of lesional tissue that would otherwise be inaccessible surgically. And then the second advantage is that there's a variety of emerging evidence that supports the effects of, or the later effects of LIT may be exploited to enhance basically tumor cell destruction. For example, disruption of blood-brain barriers that would allow the facilitation and dissemination of chemotherapeutic agents. So we actually did a study, particularly looking at whether or not the degree of cytoreduction conferred with LIT was associated with survival benefit for patients that were treated primarily with LIT with newly diagnosed GBM. Shown on the right was one of the patients in our cohort who had a particularly significant splenium GBM that was crossing midline that would otherwise be inoperable, that was treated with a gross total ablation using LIT. We found that similar to resection thresholds, there also is a ablation threshold with LIT that if 70% or more of contrast enhancing tumor burden is ablated with LIT, that was the threshold that conferred a improved progression-free survival benefit in our patients, as well as an overall survival benefit, although this was not statistically significant, likely secondary to the our small sample size. What was quite interesting, as before I mentioned LIT, one of the advantages of the LIT was it potentially disrupting the blood-brain barrier and allowing for increased efficacy of adjuvant chemotherapeutics. And one thing that we found with this study was that the time to initiation of chemotherapy was a significant predictor for survival outcome, and that patients who received chemotherapeutics earlier during the postoperative course actually had an improved survival benefit compared to patients who received chemotherapy later, earlier being within postoperative day, within 16 days post-op, and then later being later than 16 days. Obviously this has to be weighed with the potential disruptions in wound healing and the higher, risk and incidence of postoperative wound infection. And then the last thing I want to mention in regards to minimizing neurologic morbidity for glioma surgery is this arising field of connectomics. So I think connectomics allows us to, or is kind of causing a changing paradigm shift in terms of redefining exactly what an eloquent tumor truly means. As an example shown on the left is the traditional dogma in terms of defining eloquence, which is really just isolated regions of the brain, notably, motor, sensory, language, and visual areas. However, as we're seeing, the definition of eloquence is really quite more complex than that, and that deep white matter tracts and association areas actually have quite a large influence in terms of maintaining a patient's neurologic function. So, as mentioned, the traditional definition of eloquence was limited to sensory language and visual cortices. Obviously, this has two major consequences. The first consequence is that patients with, tumors within those regions or tumors defined as eloquent are generally not elected for resection. And then the second consequence of that is that tumors outside of those areas are deemed non-eloquent and are frequently operated on without mapping. However, again, it's obvious that the structural functional connectivity of the brain is much more complex than that, which is shown here in a recent paper published by Dr. Ivan, Dr. Segru, which showed that there is a variety of these networks, including the language network, a dorsal attention network, ventral attention network, which all contribute to what a patient's neurologic baseline. And therefore, a strong understanding of each patient's functional connectivity may allow us to basically have a more personalized approach to the benefit risk ratio for each patient in terms of offering them surgery and how aggressive to be with resection. So, the continued use and study of connectomics, I think, is a promising aspect or field in neurosurgical oncology that may allow for more personalized medicine and may aid in optimizing the benefit risk ratio for glioma surgery. So just in conclusion, multiple studies have shown a strong correlation between maximal safe resection and patient survival in GBM surgery. Emerging evidence supports extending resection margins beyond the contrast enhancing border. Aggressive cytoreduction must be balanced with the preservation of neurologic function and minimizing neurologic morbidity. However, there are a variety of novel and emerging techniques, including SRH, LIT, 5-ALA, and connectomics that may aid in optimizing the benefit risk ratio for each patient. Thank you.
Thanks, Long. That was a great talk. Just based on your extensive work in this, what do you think are the future directions that you want to take this project to? Like, there's a lot of data on molecular markers, in the periphery, in the flare area versus in the contrast enhancing area. Do you think there's any role for kind of local regional sampling in these supermaximal groups, or?
Yeah, I think one of the main, you mentioned, kind of the molecular subtypes of these tumors, and I think more and more the in terms of the tumor defining tumor subtypes and the correlation with patient outcome is becoming more and more based on molecular characterization as opposed to gross evaluation, with histopathology. I think one of the really promising parts of SRH, which I mentioned before, is that what is its ability to potentially even detect molecular subtypes without sending tumor samples for molecular characterization or next generation sequencing or anything like that. I think there's a lot of emerging studies now that have been looking at the utility of SRH in terms of identifying molecular subtypes, which can kind of further help surgeons decide how aggressive they need to be in the OR.
Yeah, I completely agree. I think that's really important that we're using these technologies like in real time. I mean, what do you at Miami? What do you think the barriers are between us using it? We have the Raman histology machine, but it's not used nearly as much for every glioma. So, what do you think the barrier?
That's a great question. I think, well, I mean, like a large portion, I guess, of the a large portion of our tumor surgeries are also done at Jackson, and I think just in terms of kind of getting past the red tape and also making sure that the admin is I guess okay with us kind of utilizing these new technologies in the ORs here at Jackson is also maybe contributing to that as well. In terms of the barriers, using it over at I think obviously just training people in terms of being able to generate the squash preps appropriately and being able to use the machine, I think that would probably be the largest barrier. But aside from that, I think just the efficiency in terms of generating a pathologic or neuropathology image is a lot more expeditious than traditional frozen section would be. It's just the kind of getting over that mental hump of being able to learn how to use the machine and training the staff on how to use it as well.
Yeah, I mean the system is actually very easy to use. The problem is, I think, is that nobody, the log information is not really clear, and also using it and putting the sample in the actual machine isn't that obvious. So maybe having a training session, because I think we're underutilizing it, and there's like the AI machine. And I know you kind of mentioned it a little bit, but in that machine, you can actually, it says, oh, this is 75% tumor, 25% normal, and it gives you an AI kind of, a response on the tissue you're sending. And so, making sure we all have the logins for this and making sure that the residents know how to use it will be very helpful, because, if only like 1 or 2 people know how to use it, it's not going to be, as utilized, I think.
Yeah, exactly. Thanks, Ashish. Okay. All right. Thanks, everyone.